Today's Grand Round is actually a GI Grand Rounds, and we'd like to highlight some of the excellent work done by our colleagues surrounding quality safety and patient safety in our department. So I'll introduce our speakers. We have Dr. Loughney and Dr. Mark Mattar. Dr. Loughney is currently our director of our endoscopy unit and also patient safety officer in the hospital. He is heavily involved with our monthly quality and safety conferences. Dr. Mattar is our fellowship director for the program, also our quality improvement officer as well for our department. He also is the director of our inflammatory bowel disease program. He's also very extensively involved in quality and safety initiatives within the fellowship program as well. So I am very looking forward to hearing their discussion about today's Grand Round. So I will turn over the talk to Dr. Loughney and Dr. Mattar.
So as you know, there's actually some folks on this call who are experts in quality and safety, and we encourage you and welcome you to give us your insights towards the end. Hope we can engage in some nice conversation. But this is going to be sort of just some sharing, a show and tell of what we've been doing in the GI world with MedStar over here. So just some definitions, some history about quality and safety. So our objectives today were to recognize the evolution of quality and safety in medicine and GI. By the end of this program, you should be able to appraise the value of specific process improvement efforts in an IBD, interpret quality and safety measures specific to endoscopy, and incorporate and develop small change plans and collaboratories within your own specialty. So first, let's talk about the evolution of quality and safety in medicine. So just some definitions of quality and safety. So from Institute of Medicine or National Academy of Medicine, the degree to which health services for individuals or populations increase likelihood of the desired health outcome and are consistent with current professional knowledge. And just some data, this is older data, unfortunately, it hasn't changed much, but about 500,000 deaths annually are from preventable hospital mistakes. About 1/6 of all deaths in the US each year account for this. So one of the biggest books in quality was 1999, this book, To Err is Human, published looking at public attention focused on the crisis of patient safety in the US. 2001, Crossing the Quality Chiasm. So looking at the immense divide between what we know to do in good health and what people actually receive. Quality problems occur typically not because of failures of goodwill, knowledge, effort, or resources, but because of fundamental shortcomings in the ways care is organized. So the American healthcare delivery system really has gone through fundamental changes, really trying harder really will not work, we're realizing, but changing systems of care does tend to work. So these are the 6 Institute of Medicine or National Academy of Medicine 6 pillars or 6 aims of improvement. It's called STEEP, STEEP. So we want things to be safe in the hospital, avoiding harm or injury to service users, timely, so reducing waits and harmful delays for staff and patients, effective, based on scientific knowledge for all who could benefit, efficient, avoiding waste, equitable, doesn't vary because of location or characteristics, and person or patient-centered, respectful of individual needs and preferences. So how do we improve care? So Institute of Healthcare Improvement goes through what's called a PDSA cycle. Anyone who is familiar with quality and safety and process improvements is familiar with this, or PDSA, Plan, Do, Study, Act. So first you plan, you ask the right questions and predictions, plan to carry out the process, and then you actually carry out the plan, document problems, begin data analysis, complete analysis, compare to prediction, summarize the learning, and then act on it and change what changes should be made. And it's not just one PDSA cycle over 1 or 2 years, but a quality improvement project really is a sequence of improvements, a bunch of these PDSA cycles. So there's a theory and prediction, testing under various conditions, make part of the routine operation, then spreading the change to other departments or either other hospitals. So let's talk about process improvement efforts in IBD specifically. So some things that we did early on was looking at ways we could make small steps in quality improvement with our IBD patients monitoring medication adherence, also looking on health maintenance, cervical health, pap smear scheduling, vaccinations, colon dysplasia surveillance, evaluating health literacy. And then one thing I want to focus on is the IBD Nurse Triage study. So IBD Nurse Triage study, which we published in with a previous fellow of ours, a nurse practitioner, Amy, and Dr. Choden. 1 month of patients, we looked 1 month of charts or phone calls, 500 patient call to the IBD nurse coordinator, categorized by type of concern. So about 60% male, female, about 40% male, mostly Crohn's disease. And here from top to bottom here, you can see the categorization of how much time the patients are calling in for each type of issue. So scheduling the next dose of medication like biologics was the highest time consuming process, symptom update, insurance inquiry, and so forth. And then from here, we worked on workflow changes, biologic new start package. So the IBD center, we have a welcome letter that we give to the patients either in person with their visits, their post-visit instructions after the clinic, or virtual to the portal, infusion and injection instruction, financial assistance programs and enrollment, and how patients could kind of get back in touch with us. Specialty pharmacies, so recent partnership with Shield RX. This is one of more recent endeavors with the GI department, where we actually have specialty pharmacy and a pharmacy technician and liaison on site to help kind of close those gaps, get prior authorization for injectables, and work with our patients from beginning to end to make sure those patients get the medication and stay on the medications they need. And also outpatient infusion centers, decreasing that burden of prior authorization and insurance restrictions, especially as it comes to hospital-based infusion centers. So there was a very nice article by Eugene Nelson considering patient-focused registries can improve healthcare and science. This is the first time we think of registries actually having some kind of action. So shortcomings of traditional registries, we think about feedback of data lags, unfortunately. Reliance on tedious and error-prone manual data entry can hurt us. Data may be restricted to a small number of uses or users. Limited patient involvement in the design, oversight, and operations. Something had to change. So the first process that we learned from the pediatric GI group, something called Improve Care Now. As you see from the bottom here, this included 900 pediatric GI physicians, or about 30,000 children with IBD. And we were able to see 91% satisfactory nutrition, 52% sustained remission of 1 year with their Crohn's and colitis, 81% remission, so forth. So these are all endpoints that they're able to gather from this Collaboratory in pediatric GI and IBD specifically of 30,000 children with IBD. So then the next question is, what could we do in adult IBD? And this is where the next program is I'll be talking about in the next few slides, called IBD Qorus. So this came out from Gil Melnit over at Cedars-Sinai and Corey Siegel over at Dartmouth, fostering collaboration through creation of an IBD learning health system. And what the system is IBD Qorus, like a musical chorus, but with a Q for quality. Quality-driven, care-focused. So this is with the Crohn's and Colitis Foundation, which is our most reliable foundation for our patients with IBD. So what is IBD Qorus? So it is a unifying group to form standard of care and correct disparities in treatment and diagnosis. It's multidisciplinary, it works seamlessly for a common goal. It's a learning health system, opportunity to learn and engage in quality improvement methodology from expert from IHI and other institutes, interactive system to learn from like-minded colleagues, passionate about improving IBD. What is IBD Qorus not? It is not a clinical trial protocol, not just a registry or a passive registry. It's not a way to meet physician quality reported, requirements, system requirements. It's not a replacement for electronic health records. At the time being, there are 50 sites IBD Qorus. We joined in 2016 when there was 20 sites. So every few years they add about 10 sites across the country. This is the leadership of IBD Qorus and one of the main breakthrough series collaboratives that we had, again, all the way from Dartmouth, Cedars-Sinai, and anywhere in between. Again, some experts in statistics and quality improvement on here as well. And also we have a patient advisory council, and they have rotators. So these are our patients that are involved in helping advise and collaborating with us, and we go through some of these ideas. So what is in a power of a collaboratory? And yes, collaboratory like laboratory, not collaboration. This is actually testing and trying different quality improvement processes with our patients. So currently, again, 50 practices, about 60,000 patients with IBD total. So volume is huge. Practices range from about 700 to 5,000 patients. Each practice has a team, including ours, with at least a physician, a nurse, and or coordinator, and all inviting patients. Mix of community-based practices and large academic referral centers are involved in IBD Qorus. Patients include in leadership and design teams again, and learning sessions we have in person, now virtual, about 2 times a year, and monthly webinars where we all meet virtually. So what are some change ideas for improving urgent care? This is one of the breakthrough series platforms that we use. So how can we help improve urgent care for IBD patients? So we looked at how, when, why use the ER in urgent care, direct lines for urgent care calls, an IBD line, phone calls return within 4 hours, reserved appointment slots. This is all to improve care. And this is just some generic potential processes that folks could do in their IBD programs. So how does the platform really look like? So this is based on co-production supported by the Qorus dashboard between the provider and the patient. So there are patient-reported outcome data that are input along with clinical data, CRP, calprotectin, and PROs would be like abdominal pain, diarrhea, things like that, things that are relevant to patients with IBD. And in the dashboard, it's all put together after the patient has consented online into this dashboard. So the patient could engage with this as little or as much as they would like to. So they could go online. It's also app-based, mobile app-based and online. And you can go in and look at the rectal bleeding, how they've been doing over the last year. Look at their stool frequency, abdominal pain, CRP, there's some labs here, different medications they're on, and the physician can also look at this dashboard. So this is sort of a snapshot of what this could look like for very involved patients. And there's another piece to this. I mentioned the breakthrough series. So this is a treat to target breakthrough series that we're involved in right now, and we have them for over a year now, where the patients are actually given a scantron. This is de-identified, there's no names here, and they are to fill this out. The main thing here, what is the patient's target? What is their goal of therapy? And then going through here, again, patient-reported outcomes in ulcerative colitis, daily stool frequency, blood and stool, abdominal pain, well-being, ER utilization, hospitalization, steroids, opiate use, which are all negative predictors of how the patients are doing with IBD, and then some demographic data. And then the provider actually does the back part. How well are we doing? We're talking about treat to target. What are our targets? Are we looking at for remission at the moment? How well are we doing with scheduling? How we assess whether colonoscopies, calprotectin for fecal laboratory tests and things like that for inflammation. Medications they're currently on, if something happens, they're not doing well, what would be the next step in management? And then sort of a provider or physician global assessment after that. So we're able to take this, and this is all mailed to Cedars-Sinai or each month, and then they'll produce what I'm about to show in the next slide. And there's also electronic version for our telemedicine visits. They actually are sent this online that they could fill out. So also what we can use is population management tool. We could use IBD Qorus for all this data from all these 60,000 patients. So we could sort patients in our own practice or other practices or in general by disease activity, recent ER visits, long-term prednisone exposure, narcotic use, vaccination status, and so forth. And then this one way we could use this is potential interventions for the high-risk patients, patients who always have high CRPs or inflammatory markers, patients who are always in the emergency room, and so forth. So what have we done in impacting IBD care at Georgetown specifically, or really MedStar GI? So we have implemented frozen slots on the physician schedules for new IBD patients and nurse practitioner schedules for IBD urgent visits or follow-ups. We align the central schedulers, referral liaisons, and on-site staff to appropriately schedule new patients into these frozen slots. We generate and maintain a high-risk patient list. Nurses call and message high-risk patients in the My MedStar portal. We have post-discharge scheduling with IBD nurse practitioner within 2 weeks to minimize readmissions. Weekly huddles with nurses, doctors, APCs, MAs to discuss hiccups and next steps, spread process from MDs to the APCs. We have built with the IT department an IBD note template that includes recent MR or CT imaging, Coproduction, CRP, colonoscopies, therapeutic drug monitoring levels. Next step, we are working with EHR, with IT folks at MedStar for electronic health record integration or extraction, to really help us automate this process a little bit better. This is definitely not a perfect system as folks in this group get busier with different processes throughout time. Of course, some of this may not be happening at every time, but this is what we've been working on for the last couple of years. So what can we see looking back at this? And thank you, Tina, from our department from finance, they're helping us look at our ER readmission data with ICD-10 codes for IBD, all IBD. And we're able to see with some of these interventions, again, this is back in 2018, we were able to see a decrease in our ER admissions based on some of these interventions. And then remember I showed you that Scantron in the whole system, IBD Qorus. So what that could show us is even a bigger sort of level. This is the same feature, ED utilization for our patients on top. This is us. And we started seeing a shift going down here, about 6 dots below the mean here, or the average green line here. And did start going up, but also did start going up for the whole Collaboratory. This is all the sites in IBD Qorus. Theirs kind of kept going up. This is as recent as August. But again, so this is something we continue to monitor and act upon as a Collaboratory and as a site. This is just a snapshot of one of the monthly feedback reports that we get, which include all the opiate use, the patient-reported outcomes, and all those different features that we discussed extracted from that Scantron or the online survey. So just as I wrap up here, just to give you an idea of what this looks like. So we're talking about 50 electronic health record environments, all coming down through an application programming interface into what's called IBD Plexus. IBD Plexus has IBD Qorus as a piece of this, but also IBD partners looking at specific survey-based studies that patients could be involved in. Spark IBD, this actually is a tissue-based study in IBD from colonoscopies, and a pediatric risk one. And then also, again, spits out the data for IBD Qorus. So that's sort of the bigger picture of what happens with all these pieces of data. And this is just to show you IBD Network that we've come up with. Some of the members here are our last in-person session in Vegas. And again, this is our group, working with the larger group of 49 other sites to really try to deliver quality care. Thank you, and I'm going to hand it over to Dr. Loughney now.
Thank you, Dr. Mattar. I wanted to go ahead and present different quality and safety initiatives we've done here at Georgetown Endoscopy and tell you a little bit about our program. 8 years ago, when we started to build our program, what we wanted to do was take markers that were well validated in the literature and were shown to improve patient outcomes. We wanted to focus on our highest volume procedures so that we could essentially get the most bang from our buck. And we wanted to focus on performance improvement, not critique. We tried to incorporate HRO values into the way we did our performance assessments. And we also wanted to learn from how we calculated the statistics. We wanted to ensure that the statistics accurately reflected physician and other provider performance, acknowledging that there are a number of cofactors beyond physician behaviors that have significant impact. So there are a whole host of things that we did, but I wanted to focus on 4 different initiatives that are most pertinent to the partners that we have in the hospital and that affect the care of patients that we share with other services. We're going to talk about markers of high quality colonoscopy performance, the Georgetown VTE reduction task force work, staff and patient safety in the endoscopy unit during COVID, during the pandemic, and then the elimination of direct access endoscopy that we've accomplished in the last year. So let's talk about colonoscopy performance measures first. As time has gone on, the surveillance interval between colonoscopies has gotten longer and longer, now 10 years for screening colonoscopies. And so if a polyp is missed, there is a substantial chance that that polyp could eventually become a cancer in between colonoscopies, a so-called interval cancer. And we want to do everything that we can to diminish that. Some of this was culture change. Some of this was actually measuring objective markers of performance. Culture change involved having not just the gastroenterologist looking for polyps on the screen, but have everyone in the room, with the exception of anesthesia, looking for polyps. People are closer or farther from screens. They're looking at screens from different angles. And there was very good data from Indiana University that said, if everyone in the room is looking for polyps, the adenoma detection rate, the likelihood of finding a precancerous polyp, goes up about 28%. And it was also a nice leveling of the playing field so that the hierarchical physician, fellow, nurse, technician culture was leveled out. And for a variety of reasons, that too was helpful. We wanted to focus on our complete colonoscopy rate. How often do we get to the top of the colon and do a complete exam? The colonic withdrawal time, how long does it take to pull out the scope? Importantly, the adenoma detection rate. And then we present these outcomes quarterly at our GI Patient Safety and Quality Conference. We then also, in addition to the fact that we looked at ourselves, we also wanted to look at non-operator influences on physician performance. So this was the first quality measure that we looked at. This is the cecal intubation rate. This is the percentage of the time that the gastroenterologist or person doing the colonoscopy gets the scope to the cecum so that 100% of the bowel is inspected. The national benchmark's about 95%, or is 95%. And we're all meeting or exceeding that number as a department. We do well. For gastroenterologists, this is kind of low-hanging fruit. This doesn't help us all that much. But importantly, many persons in the United States and in Canada in particular that are doing colonoscopies are not gastroenterologists. Colorectal surgeons who do quite a good job, but also at times internists, family practitioners, and nurse practitioners are doing colonoscopy. And so nationally and internationally, I think that this standard will continue to be assessed. Internally, we're doing fine here. We also want to look at the colonic withdrawal time. How long does it take us to pull a scope out of a patient? In some centers, folks are trying to do high volume colonoscopy. And if you're trying to do 18 to 20 procedures a day, they have to be done quickly. And if you're doing them too quickly, i.e. if you're taking less than 6 minutes to pull a scope out, you're probably not doing an adequate exam. The withdrawal time is a marker of carefulness, essentially, and attention to detail. Again, the national standard is to take at least 6 minutes to pull the scope out, and ideally 10 minutes. We're doing well across the board here at Georgetown. We're meeting an exceeding standard. And the way we measure this is we'll go to the top of the colon, we'll take a picture of the cecum. We'll, on the rectal retroflex at the end of the case, take a second photo. And then we use our dictator to basically pull the rectal retroflex from the cecal intubation time. And that gives us our withdrawal time. So that we're very pleased with as well. But most importantly, we focus on what's called the adenoma detection rate. This is the percentage of the time during a screening colonoscopy where an adenoma or precancerous polyp is found. Screening procedures, importantly, only include patients aged 45 to 75 with no symptoms of colorectal disease, no personal history of colon polyps, IBD, or colon cancer, and no family history of colon cancer in a first-degree relative. These other groups will bring a higher likelihood of adenomas to their exam, so these are excluded. Large population studies suggest that there's a 30% prevalence of an adenomatous polyp in men 50 to 75, and a 20% prevalence in women age 50 to 75. We don't know why males bring more polyps to their colonoscopies than females, but they do. And the reason that these numbers are important and calculating this number is so important is that for each 1% increase in a gastroenterologist ADR, there's a 3% decrease in the likelihood that their patient is going to develop colon cancer before they're due for their next colonoscopy. So this is an extremely important measure. A little bit of a busy slide, but this is the Georgetown Hospital adenoma detection rates. And again, in male patients, it should be 30%. In female patients, the benchmark is 20%. And we're doing well across the board, both in male and female patients. We measure the total number of procedures that each gastroenterologist has performed. And importantly, you don't really get statistical significance until you get around 200 cases. So people may have very high or very low ADRs until they get to around 200. The statistics will even out. And you'll note that our numbers, we think we're doing really well, but our numbers are far higher than what the benchmarks are nationally. Partly we think we're doing a good job looking for polyps, but partly we also feel that these benchmarks have been set quite low, and that with better imaging technology, the prevalence of an adenomatous polyp is actually a good deal higher than that's been published thus far. Our data reflects that of other academic centers. Couple of things we learned as we calculated the data. The blue on the left is the adenoma detection rate of 27 or 28% before we started following the ADR. And then when our group was aware that we were following the adenoma detection rate, the adenoma detection rate went up to 32%. It went up significantly simply because everybody knew that we were looking. We're all internally competitive people. We present this data quarterly at the Patient Safety Conference. No one wants to be last. So we think that this was helpful. But also equally helpful, perhaps more importantly, is that physicians need to have the adequate technology in order to allow them to do their job. In 2018, we were resourced to go from standard endoscopes and standard monitor to high-def scopes and monitor that you see in red. And across the board, the adenoma detection rate rose in males, females, and all patients because the imaging technology really allowed us to find these little 2-millimeter adenomas that are in their infancy, take these off, and years prior to the onset of cancer, remove the precancerous lesion. There were other things that we learned as we went through the learning process of how we calculate this data. In the beginning of our calculations, we calculated a total adenoma detection rate in all patients, male and female grouped together. And we looked at our ADRs as a department, and as we observed, the 3 of the 4 female physicians were in the bottom half of the cohort in terms of adenoma detection rates. And we knew our colleagues, they were outstanding. We thought that this had to be some sort of an artifactual event. And in fact, we looked at, well, female patients will more frequently go to a female gastroenterologist in most cases. Is that the case here at Georgetown? And if a female patient brings fewer polyps to their encounter, perhaps we're penalizing the female physicians. So this is the patient gender mix of the female physicians and the male physicians. And all 4 of those female physicians were seeing more female patients than all of their male counterparts. So we recalculated the data, and the results in order of ADR in female patients was a nice bell-shaped curve for male and female physicians, and a nice bell-shaped curve for male and female physicians in male patients. So we learned a lot of lessons in the last 7 years, and we feel like at some point, CMS, Aetna, Blue Cross will come to us for our data to say, you know, how well do you folks do as opposed to another comparable institution in your area or national. And we want to be very good at calculating the data. We want data that reflects, you know, the true performance of our providers. We want to help everybody who's not at the maximal standard get there. And I think that this was one of the lessons that we learned along the way. And here's our next step. We're moving towards AI in gastroenterology, and AI in gastroenterology is very similar to AI in cars. There's a lot of analogies. We have AI already. We have MapQuest. We have Park Assist, sensors around your car so you don't hit the pylons in the Levy garage. There are self-parking cars that are available. Tesla has an autopilot feature on their cars, in some of their cars, that has been variably successful, not always. And at some point, we think they're going to move to autonomous cars. We are also applying AI in gastroenterology. The time calculator that I referred to before that tells us how long it takes us to pull a colonoscope out is one version. We have a color detector, a red color detector on our capsule endoscopes that triggers each time it sees the color red. It's actually highly sensitive, far too sensitive. It's not as helpful as we'd like, but it's AI. But what we're moving to, and what we're looking at right now, is actually a couple of different vendors that are looking at machine learning to teach a computer processor, an endoscopy processor, how to recognize a polyp and somehow highlight it for the physician. The next generation after that is actually going to be optical biopsy. Can I somehow interrogate this piece of tissue with a probe or with a light source that will tell me this is a hyperplastic polyp, this has no cancerous potential, this can be left in place? Or is this an adenoma? We need to take this off. It may reduce the risk of post-procedure bleeding and perforation. It may reduce pathology costs. There's a whole host of things that are going to come from this. Level 5 autonomous colonoscopes actually have been explored years ago at Walter Reed. We looked at tracked vehicles, as it were, which could not get sufficient traction, so they never went anywhere. But we don't have autonomous colonoscopes, but that too may come someday. But more to come. I'm going to change direction here and talk a little bit about the Georgetown VTE Reduction Task Force. For years, we have had a higher than expected VTE rate at Georgetown, and there's a variety of reasons for this. Our oncologic community has a great deal of hypercoagulability. COVID actually also was associated with significant hypercoagulability, so there was an increased risk for our patients developing a DVT. But in addition to that, there's an increased risk of DVT that goes up directly with the number of missed doses of prophylaxis. This was a study that looked at Loughney, University of Michigan, published 7 years ago in JAMA Surgery. Direct correlation between the number of missed doses of prophylaxis and the likelihood of developing an in-house DVT. There's a lot of reasons why patients miss doses. However, one of the reasons is that they're going to be set up for an endoscopic or interventional radiology procedure. What we have tried to do for years is put out to the referring service whether or not it would be appropriate to stop our anticoagulation, the patient's anticoagulation prior to their procedure. And if somebody's going to have a polypectomy, an ERCP with a sphincterotomy, treatment of varices, banding of varices, or PEG placement, these are the four most common inpatient indications here for holding Lovenox or other anticoagulation. We're trying to say, okay, if it looks like your patient's going to be going for one of these, hold the anticoagulation. But importantly, what we weren't really educating, I think, as well on is that a diagnostic endoscopy with biopsy, colonoscopy with biopsy, ERCP if we're just changing a stent, or if we're putting a stent in without a sphincterotomy, or if we're doing a push enteroscopy or a capsule, we don't have to hold anticoagulation in these patients. So there were a lot of opportunities to not hold anticoagulation. And again, we weren't as clear, I think, as we should have been as to when we should hold and when we should continue. This is a survey from the hospitalists, I think about 2 years ago, and the task force found that only 25% of the time were the teams clear on whether they should hold anticoagulation or not. They were either sometimes or often sure that whether to hold the anticoagulation 3/4 of the time. So we've done a couple of things. Whenever possible, we are to make a proactive recommendation in the pre-procedure consult to continue VTE prophylaxis. When in doubt, continue the prophylaxis. For procedures with high risk of bleeding, though, ERCP with sphincterotomy, PEG placement, planned polypectomy, we have to hold the agent, but we want to give a very specific time frame as to how long we should do this. We should use SCDs during the period anticoagulation is held. And if the primary team is concerned or unclear as to whether they should hold anticoagulation, we want them to reach out to us into IR if it's an IR case to get clarity on the management. And then finally, we want a very specific post-procedure anticoagulation recommendation made in our procedure notes. So we've worked with Pentax, who I think is going to regionalize this throughout their report writer system, to add a drop-down field, mandatory drop-down field, to discuss how to manage anticoagulation after a procedure is performed. So we'll click on resume or hold anticoagulation. And if we resume the agent, there's a whole host of agents that we can click on, and then a specific time frame, today, tomorrow, or at a specific date when anticoagulation can be resumed. We think that this has been helpful. This is our data starting around the time we made these interventions, or at the time we made these interventions. This is the perioperative PE-DVT risk in endoscopy patients. And we've had a progressive decline in the likelihood of developing VTE around the time of an endoscopic procedure. There's a lot of reasons for this. Some of this, I think, has been the great work that the task force has done across the board to make sure SCDs are being used and other interventions are being made. However, we think that our pre and post-procedure recommendations have probably helped as well. And interestingly, with the exception of 2 blips, the data has been linear down. Interestingly, these 2 blips have been in the third quarters of 2020 and 2021, i.e. July, August, and September. So it is highly likely that this reflects educational opportunities on our part to educate our fellows, to make these recommendations, to have the house staff educated, the new house staff and the new to practice nurses educated, that when in doubt, we should be continuing anticoagulation and that we should be looking for very specific recommendations when to hold. I'm going to talk briefly about what we've done for endoscopy and patient staff protection during the pandemic. As things unfolded in March of 2020, we had, happily on some level, the benefit of the experience of others, both in Asia and in Italy in particular, as to how they handled the pandemic from the perspective of endoscopy. We reached out to Alessandro Rapici, who's a colleague and is the endoscopy director at Humanitas Hospital in Milan. And he had looked at 968 endoscopy personnel, physicians, nurses, techs, anesthesia providers in 42 centers in northern Italy. And what he found was about 4.5% of the endoscopy workforce developed COVID. 36 of the 42, or 85% of the infections occurred prior to the introduction of very strict PPE and later case reductions. They couldn't track definitively that these 4.5% were occupational or community acquired, but because these are all aerosol generating procedures, it was felt that at least a good percentage of them were workplace acquired. So we adopted their model. This is former STAR medicine resident, now STAR GI fellow Mark Reel, who is wearing what we wear in endoscopy now because all of our procedures are continuing to be aerosol generating. We have a hair cover. We have an N95 mask with a standard mask over it. Everybody's in scrubs. This is about the 4th time in 2 years I've worn a tie, I think. Face shield, impermeable gown, water impermeable gown, and 2 pairs of gloves. And there's been other interventions as well. We have pre-procedure rapid antigen testing. We have surveys, questionnaires to our patients to assess for symptoms suggesting COVID infection. However, we have a fairly strong assurance that we have not had a staff member acquire COVID from a patient in endoscopy, or that a patient has gotten it on the endoscopy unit. And I said, this is not just the PPE, but I think that this helped a great deal. One of the other things that we did was we very dramatically, happily temporarily, decreased our caseload in endoscopy. Up until the pandemic, we were doing about 1,000 cases a month on average in endoscopy. And we very rapidly drew down out of necessity to preserve PPE stores when we weren't sure how long the stores would last. Kudos to Whitney Taylor and her team, who have done extraordinary work. But we also were unsure with aerosol generating procedures whether it would be appropriate to bring people into the unit at all. And there's benefits to safety to the patients and safety to our staff, but there are also significant risks. Again, we had folks whose pandemic predated ours by about 3 months. This is data from Hong Kong, where they looked at their drawdown in cases before and after 20 January of 2020, which is when they started to cut back. Their endoscopies decreased by 51%, and their gastric cancer diagnoses decreased by 46%. Their colonoscopies decreased by 59%, and their colon cancer diagnoses by 37%. So they estimated over a period of 6 months that gastric cancers would wind up being upstaged due to delay in diagnosis in 5% of cases, and that colon cancers would be upstaged by 6%, again due to a delay in diagnosis. So we tried to figure a way that we could bring in the people that we absolutely had to and defer the folks that we could. And this was a matrix that was published by the New York State Gastroenterology Association. And this is the matrix that we and most others used. The priority ones, and we did almost only the priority ones initially, folks with GI bleeding, dysphagia that put them at risk for aspiration or malnutrition, cholangitis, palliation of malignant gastrointestinal obstruction, gastric outlet obstruction or colonic obstruction, PEG tubes for feeding, or particularly in our IBD population, cases where a procedure would urgently change management. There was also a group that was easy to defer: colon cancer screening, surveillance for polyps, Barrett's screening or surveillance, or screening for esophageal varices. The groups in 2 and 3 were a harder call. It was a softer call. And we did some of the priority 2s, but almost all the cases for that month and a half were priority 1. And we still were doing 200 to 250 cases, primarily because the oncologic community that we have here. Happily, we have not seen delays in diagnosis. We think that this matrix worked. So we're relieved to have that occur after a period of observation. But a lot of folks put a lot of work into this, and we're very grateful to them. Last thing I'm going to very briefly touch on, because I think we have enough time, is the elimination of direct access endoscopy here at Georgetown. Georgetown GI and most centers use direct access endoscopy, which involves patients who are referred by a provider or who have had a procedure with us in the past, call for an appointment. Telephone triage was performed using a very specific set of criteria that we and the anesthesia department developed to assess their ASA status for the strength of the procedural indication and for other things like anticoagulation that would affect their procedure. But there were some significant challenges. The medication list was not always complete. Occasionally, patients would come in on an anticoagulant that we were unaware of. Patients most frequently underemphasize their comorbidities. Referring physicians, importantly, may not have known that the screening and surveillance intervals had changed, particularly for colon cancer screening. And we're not doing colonoscopies every 3 years on patients' NATA survey for polyps. Patients frequently self-referred for a procedure. I want a colonoscopy is not an indication for a colonoscopy, but we saw that happening. And then we also found that there were other gastrointestinal issues that weren't being addressed. If somebody was referred for a screening colonoscopy, we can do that. But in the retrospectoscope, they actually had severe reflux or some other gastrointestinal complaint that would have merited a change in the procedure that we didn't know about until the day of their arrival. So this is the ASA class. Healthy patients and mild to moderate systemic disease, well-controlled hypertension, and diabetes, essentially, ASA 1s and 2s, are the group that are best taken into a system through direct access endoscopy. ASA 3s, 4s, and certainly not 5s and 6s can't be taken in. This is what an endoscopy unit in an ambulatory surgery center patient mix looks like. 95% of the patients are ASA 1 or 2. So we wanted to see how close to an ASC does our patient mix look like. And so thank you very much to Molly Leahy, who did great work to help us calculate this information. We looked at all the ASA class of patients who are undergoing an endoscopy or a gastrointestinal procedure at Georgetown between August of 2018 and November 2019. We selected these timeframes to minimize the impact of COVID, which skewed to a much higher ASA risk during the pandemic. We looked at 10,780 patients, and then we did some subgroup analyses that I'd like to show you. So again, that's what an ASC looks like, 95% ASA 1 and 2. This is what we look like. Only about 48% of our patients were ASA 1s and 2s. The interventional gastroenterologist had fewer ASA 1s and 2s. The hepatologist had no ASA 1s and they had almost no 2s. And these are the transplant patients that we see. So the ASA mix at Georgetown endoscopy is not appropriate for direct access endoscopy. So we were able to resource the visits for all patients who are now seen by a physician or an advanced nurse practitioner. We focus on the procedure indication, anticoagulation use, and comorbidities. And we recommend to modify or defer the procedure non-infrequently. Many times we'll tell patients, you know what, congratulations, you're not due for a colonoscopy yet. And we're educating physicians, nurse practitioners, and particularly those in the community on screening and surveillance indications. And initially, we thought that our volumes would suffer as a result. I'm afraid that has not happened. Our volumes have increased significantly. We're now booking many of us in January or even February. But I think we're doing a better job at triage. I think the patients, the procedures will be safer and better indicated.